Okay. Say we were the English and investigative education in guiding according to the vibes we have on the parent group all over the place. I don't think there's an explanation. Paper with the parking, every good result. After 1 to 1 and setting out on a shield or just for life of the parents conference that we have here. And she really agreed to participate in the state of Columbia to be huge hope about the future and recent progress in the Thank you very much for
Can you hear me? Okay. First of all, I'd like to thank the organizers for giving me the opportunity of presenting the results of our research today. It is a pleasure and an honor for me to be present, even if only virtually. And I will, in the next 15-20 minutes, I will introduce you the results of our research on the use of CAR T cells for the treatment of neuroblastoma. And this is the agenda of the talk. We will first go through a general overview, then we will talk about the mechanism of action of CAR T cells, and then we will enter into the details of the research that we performed and the outcome that we observed. When we talk about CAR T cells, what we are talking about is in general an approach that refers to the immunotherapy type of treatment. And by immunotherapy, we mean every treatment option which harnesses the abilities of our own immune system to recognize and attack cancer cells. And why do we have this kind of therapeutic approach? Because in general, our immune system is able to recognize and eliminate the cancer cells that normally are generated over time. The creation of cancer cells is quite an unusual phenomenon in every person. But what happens is that normally the immune system, through the different cells involved, is able to recognize these cells and eliminate them in order to induce the tumor suppression. This phase is called elimination and is able to induce the so-called cancer immunosurveillance. What happens, for reasons that we still don't know exactly, is that in some circumstances, the cancer cells become able to reduce the activity of the immune system, and therefore we enter in a phase that is called the equilibrium, in which the cancer cells are generated and eliminated more or less at the same pace. And in this case, the cancer remains quiescent inside the body without giving clinical signs of the disease. From this equilibrium phase, what can happen is that at the end, the immune system can overcome the tumor and again lead to the tumor suppression. And this is what happens in most of the cases. But unfortunately, in general, in patients that develop a tumor, the clinical disease, what happens is that instead the cancer cells can become more and more able to escape the surveillance of the immune system, and therefore they become able to proliferate and regenerate quicker than how the immune system is able to eliminate. And at this point, the disease occurs, and this phase is called escape. And what the immunotherapy does is using different strategies in order to go back from the escape phase of the immune surveillance to going back to the full active cancer immunosurveillance. And what are the advantages in general of using an immunotherapy over conventional approaches? First of all, the cells of the activated immune system are able to recognize and target also remote areas of the cancer that cannot be accessed by traditional surgery and often also by other traditional approaches such as radiotherapy. Moreover, the immune system is able to target not only the cells that rapidly divide, such as the chemotherapy and the radiotherapy, but is able to target also those cells that are more quiescent, and this enables a wider activity of the immune system. Moreover, and this is very important, stimulated cells are able to target only the cancerous cells in a specific way, while leaving the healthy surrounding tissues intact and healthy. And this leads to an occurrence of fewer and less devastating side effects than traditional therapies. And last but not least, an important aspect that it's a great potential of the immune system is that it possesses a proportion of cells which are called memory cells, which are cells that store a memory of whatever they have been fighting for, and so they are able to reactivate once the cancer it tries to relapse, and to destroy the new cancer cells that are coming back. There are several immunotherapy strategies. I will not obviously go through all of them because it's too technical. What we will focus our attention on, as anticipated, is the use of CAR T cells. CAR T cells are T cells, which are an important part of our immune system, which are gene modified in order to redirect them against the tumor cells. And once the CAR T cells find the tumor cells, they become activated and they eliminate the tumor cells. And CAR T cells belong to the field of adoptive cell therapies, which are all the field that is able to tackle the tumor by the use of lymphocytes. And in terms of historical perspective, the first attempts to eliminate the cancer with the use of this part of our immune system dates back in 1964, when the first lymphocytes were used to inhibit the growth of a specific tumor inside an animal model. Through all these years, the field has been enlarging, largely providing more and more exciting results in the clinic. But for sure, in an historical perspective, the most important step forward came at the beginning of 1990, when the group of Escher and colleagues first developed this new concept of a new molecule, which they called T-body. And the name itself already anticipates what this new molecule is made of, because it is a combination of the T cell of the immune system and an antibody. And I will explain you now why we combine these two molecules. And this brings me to the mechanism of action of this system, which was first called T-body and then was further developed as a CAR. As I was mentioning, the concept at the base of the functioning of a T-body or of a CAR T cell is the combination of the function of the T cell and the function of the antibody. Of course, I will not go through all these details of the cartoon explaining how the T cell works, but this helps me to show you that the T cell, which is one of the most active component of our immune cell, which is able to eliminate infected cells, but also tumor cells, meaning all those cells that shouldn't be present in the body in order for us to be in good clinical condition. These T cells have a mechanism of action which is quite complex, because before recognizing the cells that shouldn't be there, they first of all need to be primed by another cells, which is called antigen presenting cells. And most of all, in order to recognize it, they need to recognize a molecule which is present on the target cells, which is called MHC. And why is important? This is important in the context of cancer, because one of the main mechanisms by which the tumor cells becomes invisible to the immune system is that they simply remove the MHC molecule from their surface. And in this way, the T cells will never be able to recognize and kill them. On the other side, this activity has been combined with the activity of the, as I was mentioning, of an antibody. And why? What is the advantage of an antibody? An antibody is a molecule which is by itself able to bind to whatever antigen, whatever protein we choose on the surface of the cancer cell. And by binding it, it recognizes it. On the other side, the backside, I would say, of the monoclonal antibody is that in order to induce the killing of the cancer cell, in turn, the monoclonal antibody needs the activation of other cells of the immune system, such as macrophages and NK cells, or of the complement. So it needs a fully active immune system in order to be able to lyse the cancer cell. And none of these cells is as powerful as the cytotoxic T cells. And so what the great idea behind the CAR molecule is what I was mentioning before, combining the good sides and the advantages of each one of these two components of our immune system to create a new weapon against the tumor. This weapon is the CAR molecule, which acronym stands for chimeric antigen receptor. And the way it works is by combining the recognizing portion of the monoclonal antibody with the activating portion of the T cells. The so-called CAR molecule, which is depicted here on this cartoon, is therefore able to recognize the protein expressed on the tumor cells that we select. For example, in case of a neuroblastoma, is the GD2 antigen. And once it binds to this antigen, it's able to activate the signaling of the T cells and to induce it tells to the T cells that it needs to kill and lyse the tumor cells that is expressing that antigen. And how does it work in the clinical scenario to get to this approach? We have our patient. What we do is that we collect the T cells from the blood of the patients. We send them to a specific laboratory, which is extremely technically enabled to manipulate these cells and to gene modify these cells. And we modify them with several methods. Normally, they are viruses, which are able to take our gene of interest, which is the gene veiculating the CAR molecule, inside the genome of the T cells. Once we have created these CAR T cells, the cells are expanded in vitro until we reach the cell dose that we need, and they can then be administered either after cryopreservation, so after freezing, or freshly at the end of the manufacturing. Normally, before infusing these cells, we administered chemotherapy, which is called lymphodepletion chemotherapy, which is combined of two drugs, normally at low doses. And the meaning of these cells, of these drugs, is to create inside the body of the patients the room for the CAR T cells to grow and expand. And of course, also CAR T cells, as all the treatment, has some peculiar toxicities. These toxicities are mainly acute toxicity, which occur normally in the first month after infusion. They can be also very severe. The most common is named the cytokine release syndrome. It's an inflammatory toxicity, which is characterized conventionally by fever and malaise, and it can be in the most severe form associated to hypotension and also cardiovascular failure or respiratory failure. But in any case, it's a toxicity that ends once the cells stop doing their work, stop killing the tumor, and gets deactivated. So it's a short-term toxicity, which we became very good at managing, and there are nowadays several guidelines that guide us to the treatment of this toxicity, and once administered in a center which has expertise in the management of this toxicity, is nowadays reversible in the vast majority of the cases. the CAR T cells are also able to induce a cytopenia, so a reduction of all the blood count, which sometimes can be also prolonged. And another typical toxicity is called neurotoxicity, and it's an inflammation that happens inside the central nervous system and can lead to migraine, alteration of the consciousness until a status of coma. But again, also for the neurotoxicity, we have developed specific guidelines, and nowadays it is reversible in most of the cases. And for the GD2 construct specifically, it can lead to the occurrence of pain because of the expression of the GD2 molecule also on the fiber that are veiculating the pain feeling in the body. But beside this toxicity, which can be, again, severe, but they're all acute, the important thing is that once they resolve, conventionally, the CAR T cells are not associated with long-term toxicity. They are most commonly seen with chemotherapy and radiotherapy. And so, hoping that I gave you a nice background to further proceed with our research, what we did back in 2017 was deciding to invest on our construct. You can see the diagram of the construct at the bottom of this slide. It is a CAR molecule which targets the GD2 antigen on the neuroblastoma cells. It's a third generation construct, which means that it includes some molecules which are able to induce a higher potency of the activation of the T cell. But most importantly, you can see here that it's linked, it's associated with another gene, which is called inducible caspase-9. And this gene is a safety switch, which we include in our cells, and that we can activate whenever we feel it's important to control the toxicity. And this leads to the death of the CAR T cells. So this is a safety switch that we can use in case of toxicities that we think are too worrisome. And in the statistics that we just published in the New England Journal of Medicine, we analyzed the first 27 patients enrolled in our trial. As you can see here, the age was ranging between 2.5 years and 18.5 years, with a median of 6.7. All the patients had received several lines of treatment before being treated with CAR T cells. So these are kids in which several lines of chemotherapy and radiotherapy had previously failed. Half of the patients had a refractory and half of the patients a relapsed disease, and we had 26% of anemic amplification. The disease was had multiple sites of localization, as you can see here, and the MIBG score was elevated in 1/3 of the cohort of the patient. So what we observed in terms of toxicity was that the treatment was overall well tolerated, better than we were expecting at the beginning. The main toxicity that we observed was for sure the hematological toxicity, which was severe in most of the patients, but resolved in almost all of the patients within 4 weeks after infusion. And the second important toxicity that we observed was the toxicity that I was mentioning before, the cytokine release syndrome, which was, however, mild in most of the patients. By mild, I mean that all these patients had only fever, very mild and quick hypotension, and none of our patients developed cardiovascular or respiratory failure, except for this single patient who developed a grade 3 CRS and had a moderate respiratory failure, which we were able to manage anyway in our unit without needing of ICU. And how this translates in terms of clinical response and outcome of our patients. This graph is a summary of all the things that all the patients have received and all the outcome that we observed. And this is the summary. Overall, out of 27 patients treated, in none of them we were able to obtain a complete remission of the disease, and 8 of them a partial response, with an overall response rate which was ranging in the order of 63%. Moreover, 3 of the 8 patients that developed a partial response were actually having a persistent MIBG disease, but the PET scan was completely negative, meaning that the disease was not metabolically active, and they all presented a persistence of this response. And this strongly suggests that actually those PR are indeed true complete remission. But of course, only the time will tell us whether these patients really achieved a complete remission or not. And these short-term results translated in encouraging long-term results, with 36% of the patients that received the recommended dose who achieved a 3-year event-free survival. And these results are very encouraging if we consider that, unfortunately, for the cohort of patients that were enrolled in our trial, normally we consider a long-term event-free survival of no more than 5 to 10%. And what we were also able to observe in our cohort of patients is that if we are treating our patients with a low burden of the disease, which means less than 7 of MIBG Cytopin score, or less than a bulky disease with a longer diameter, less than 5 centimeters, and less than 50% of bone marrow infiltration of the disease, well, these patients fare particularly well, with a possibility of 3-year event-free survival, which is approaching 60%. And so overall, what we can conclude is that the GD2 CAR T cells can be successfully manufactured from children affected by relapsed refractory high-risk neuroblastoma. The treatment with these cells is associated with specific toxicities such as CRS and hematological toxicities that can be managed in a dedicated unit. The presence of the suicide gene is able to increase the safety profile of the approach, and most of all, GD2 CAR T cells are associated with a strong anti-tumor activity, which leads to an overall response rate of 63% and a general 3-year event-free survival of 36%. And as I was just mentioning, importantly, low disease burden at the moment of infusion is associated with a significantly higher probability of long-term survival of our patients. And with this, I conclude my presentation. I'll be very happy to take any questions, and I thank you for your attention, and I thank once again for the opportunity of presenting, and this is also my email in case you want to ask a further question after. Thank you very much. I cannot hear you, actually. A bit far away.
So, yeah, we can hear you. So
Okay.
thank you very much for making this process here. We hope to all of us. And we appreciate it very, very much. If anyone has questions, this is the time now to ask. If you have, I'm repeating what I said at the beginning here, but I also said that if anyone needs translation, you need to Hebrew. So part of the thing that is like for medical issues, professional language. So we have great support here. Give me like the question. Thank you so much for the talk. this to confirm the results of the lifetime study days. What this is the question, what will happen now from A to B and first treatment, and what will be the results from another source. It would be a nice for first line treatment because we see that the toxicity is much less hard than the toxicity that we have with first line treatment. And also whether there is a trial that opens that will be available in the trial.
I'm not sure I got because the noise is very, the sound is very bad. I'm really sorry. I don't know if maybe anyone can type the question in the chat.
Matthew is writing the question and is texting the question in the chat.
Thank you. Okay, thank you. Now I got the question. So, well, this is an important question, so thanks for raising it. So, well, it's two different aspects. So before moving to first line, we have to confirm the results that we obtained, because the results that I showed you are on a small proportion of patients that we treated in a single center approach. So we first have to confirm these results, and especially by treating only those patients that we know that are able to have a good long-term response. So those patients with a low disease burden. And after confirming these results, we will open other studies to include the approach in earlier phases of the treatment. And if the results also in earlier phases will be the same, or maybe even better, because the patients will have received less lines of treatment, we will be able to finally get to the first line of treatment. So this is the way normally this kind of research has to go. And at the moment, the next step is to open a multi-center European trial to confirm the results that I just showed you. So what we are working on at the moment is exactly this, planning a European trial to include centers from most of the biggest countries in Europe, so that we will be able to confirm the results also in other centers. And this is what we are working on. I don't have currently a precise timeline for when the trial will open, because we are working on this at the moment, but this will be the next phase.
The second question is, we talked about how the group of patients with the best outcome, the response to the treatment, are the ones at the lowest disease burden at the time of the treatment. Right? Probably have too few patients now to tell what is their characteristics of those patients, but do you think we will be able to enroll enough patients that we already have an idea of what features there are that predict response that achieves this kind of low burden, disease burden?
Okay, I'm receiving the question. Okay, okay, so, well, actually, this is an important question. We don't know actually yet what determines why some patients can achieve lower disease burden and why others cannot. In the cohort that we treated, actually they were all patients that received more than the first-line treatment, so it's very difficult to understand this. We will be able to have more data on this when we will treat all the patients in the same disease phase, so after the failure of the first line, because in this moment the cohort of patients that we treated is very heterogeneous, so they received several lines of treatment and they were all different one from another, so it's very difficult to respond to this question now. What I can tell you is that what we have seen is that when a patient has a high disease burden, this burden of disease is able to deactivate the CAR T cells. So even if the CAR T cells are still circulating, they don't work anymore. And this is probably mediated by some other immune suppressive components, which are more present in a high disease burden than in the case of low disease burden. So this is what we have found so far. But of course, we are working hardly on this to understand exactly how to improve the outcome of the patients so that more patients can achieve better results. Anti-GD2 CAR T as compassionate use. So at the moment, we are treating, even if the trial is closed, we keep treating patients on a hospital exemption basis. The compassionate use program, it's a different kind of program, but at the moment, we don't have a compassionate use program open. And so the options at the moment, the only option at the moment is to have a hospital exemption treatment at our hospital, which we do. And hoping that soon we will open the clinical trial. But the treatment of the patient is still active, even though the clinical trial is closed. But we don't have a compassionate use program active yet. Thank you very much. I'm sorry that I couldn't hear very well, but it was really a pleasure to be here. And if anyone has any late questions, please feel free to email me. Thank you very, very much. Bye.